But, you know, that's 2 liter. It's 2 liter.
That's a
Not
lot.
milk.
I mean,
It's 2 liters.
I drink that much, but yeah, like my husband and a lot of people I know don't drink near that much fluid. So
This got a place that talks about the heart anatomy. We talk to them. Surely by now they know, you know, if they're getting on Milrinone, they have an idea, but we go ahead and talk to them about right-sided or left-sided heart failure. Got a thing on here, green light signs and symptoms of, you know, CHF or heart failure. Swelling, weight gain, chest pain.
So is Milrinone like similar to like a Didge or something? What I don't know
Milrinone.
at all.
Okay, Milrinone, and I'll read it. It's inotropic, and what it does, it helps with a contractility.
Okay, so like Dopamine or something.
And I don't think Didge is an inotrope.
No, that's
It's digitalis helps with rhythm.
That's a different.
But this one actually helps with the squeezing.
Okay.
Yeah, it's like dopamine or dobutamine.
Oh, okay.
It's like one of those, dopamine or dobutamine. And
It's Primacor.
Primacor is what it is. And so what it helps is inotropic is the squeezing and chronotropic is the reach. And so inotropic, it helps the muscle, actually this flabby muscle. And the way I've worked in coronary care for 5 years. I was an ICU nurse at Methodist, and they were just starting to do heart transplants, and so we would keep all those patients, you know, in the ICU. Well, before there was none of that home stuff. They were just starting to do home inotropic therapy, and that's been 20 years ago.
That's nice.
Maybe 15 years ago, 15 to 20. So yeah, life has changed, but and we would have them on dobutamine. As long as they were on dobutamine, they were fine. And we do dobutamine out of this office, but this has got a great, again, it's got that glossary, and it's got aneurysm, and it talks about the medicine. Well, no, let's see, they have the PIC line in here, how to use the pump. Here's common cardiac medicines, and it has a Primacor, which is Milrinone, and it talks about what it does, talks about the signs and symptoms, and I talk to them about it. And that's section 8. It talks about that. One of the things that it does, it helps with the contractility, but it also dilates. Unlike dobutamine, it dilates all their peripheral arteries. It dilates all arteries, and I think it may be all vessels. I'm not sure what it says in here. So you know if you're all blood vessels. So you know if you're dilating blood vessels, that's that much less pressure that the heart has to work against, right? And so it works in 2 ways. Helps with the actual contractility, improves that muscle contractility, and also because your blood vessels are dilated, you don't have the pressure to push against. The heart doesn't, the left side of the heart doesn't. Now, having said that, if your blood vessels are dilated, guess what? You're going to have low blood pressure all the time. And this medicine will make you have low blood pressure. The normal range, there's a lot of folks that walk around with 89, and that's their systolic blood pressure, and they do fine with that. Now, there's some that, you know, it's a real small window. Well, when I'm 92, I feel fine. When I'm 89, I'm dizzy. And part of what you teach them is, you know, you can't just jump up anymore. Of course, most of them say, I haven't been able to jump up in years. They do. They're so, you know, debilitated by the time they get on this because they're, A, waiting for the heart transplant, LVAD, or this is a stopgap for one of those things, one of those interventions. So that's one of the things you have to talk to them about, being dizzy. A lot of folks will go home on it, and unfortunately, again, it's adults. Physicians make them wait 4 to 5 days before they're going to do anything, especially the ones out of Medical City. You know, they want to see. They want to have a little adjustment period at home, okay? And I tell them, so if you've been dizzy every day for the last 5 days, I mean, you go ahead and call your physician and let them know what's going on, and chances are they're going to make you, you know, they'll make an appointment for you on Monday. So, you know, that's Wednesday, and Monday it's been 7 days that they've done it, they've tried it. And there's been plenty, not plenty, but some where they'll adjust the dose. They'll go back in to see the physician and adjust the dose because they're just not tolerating it. But they want them to, I mean, they know that they may have some of that orthostatic hypertension with it. So you do talk to them about that. You talk to them about diuretics. You talk to them about keeping in contact with their home health nurse and letting them know if you've had that weight gain that they were talking about, 3-pound weight gain overnight. That's a red flag, or 5 pounds in a week, because they'll get into congestive heart failure. A lot of them are non-compliant, but, you know, if their clothes don't fit, a lot of folks, too, we talk about swelling, they have edema in their belly, in their gut. Their pants don't fit. It's not in their legs. It's not in their hands. It's in their gut. So that's where they do the third space. And so, I mean, you talk to them about are your clothes fitting tighter. And that's the other part of what I do. I call these folks back and find out how they're doing on this medicine. What else? It talks about diuretics. Some of the physicians, after the patients are on this medication long enough, instead of having to come in, if they catch that sort of thing early enough, they'll go ahead and tweak their diuretics and say, well, why don't you try this? And, you know, so we tell them, tell your home health nurse, and she can contact your physician sometimes instead of having to go into the hospital or see your doctor. If you catch it early enough, they'll give you a little bit more diuretic, you know, for a couple of days. So, and that keeps them where they're not so short of breath. Talk about ACE inhibitors. Milrinone works with ACE inhibitors. I know that's one of the things. Or angiotensin converting. So they're usually on, angiotensin 2 receptor, ARB. I don't know, I mean, the two together. So usually they're on some kind of Cozar or a lot of them are on Cozar, it seems like. Well, maybe it is ACE. I'm trying to think. I'm not the real good nurse to do this one.
So there's usually a combination therapy where the two drugs work together.
Yes.
Okay.
Yes. They're not just usually on one. They're on Milrinone and all their cardiac drugs, and it's usually a combination. You're right. And then we go into the staff diet, and we talk to them about that. That's the other part. Your doctor's going to want you to go on that low sodium diet. This actually talks about low sodium diet and how you can actually reduce your hypertension with it. That's what DAS stands for. Dietary approaches to lowering your blood pressure.
It's awesome. It's fun.
But if your blood pressure is very low, is it more like a restriction with fluids?
It's a sodium restriction and a fluid restriction, because it's a real fine line. It doesn't take anything for them to get into CHF. They start retaining fluid with that sodium. You know, the fluid follows the sodium. So if they don't stay under that, that salt, that low salt, and it's a big change. I mean, you can't go out to eat. If you go out to eat and you eat one meal, you've eaten above and beyond your sodium intake. So we talked to them about that, and we talked to them, and here's some recipes, and again, you know, you have an opportunity to read this book and look at it. And then there's notes. I mean, that's about it with this one. I go through the same thing as far as hooking them up. I go through the same pump, different pouch, same thing, put it in, show them about where it's going to kink. It's a 500 cc bag, and these guys can. I mean, they can. Obviously, you can carry it around. It can get heavy, but after these bags last 3 days. If they're on dobutamine, it lasts 2 days. I didn't know that the other day. I was telling everybody, 3 days, and then no. The person in the supply person said no.
So the big difference is just like you don't flush with the
dialysis, right?
That's correct. I forgot about that. That's right.
Did you give them a
The
bolus?
other thing is if they have a single line, what we do, so we do the teach, then when they go home, usually we'll bring up a bag of medicine and the supplies and extensions. If they have a PICC line, they need to have extensions so they can take care of themselves. I brought those too, because you may,
Yeah, make sure there are 10 inches on there, because we have the 7 inches too. Make sure there's,
these are 12.
Oh, they're
12
12?
and 14. Yeah.
Oh, okay.
I think that's a 14.
These are nice long ones.
The little short ones, this one, that's 12. I always get the long ones, but this is 12. But we do have the short ones.
Yeah, I carry those around in my car.
So you want to make sure you bring those if somebody calls and says, hey, can you come by the office and get some, and start a patient. So, we don't have a license to practice in the hospital, so they have to do it themselves. You get the nurse to change the extensions in the hospital. You can bring those extensions, because a lot of times hospitals use different types of end caps and things, and so we get them to change the extensions, to flush it. A lot of them will draw back the blood because the concentration in the hospital is different from this concentration, and so they don't. And that, I didn't know that either. I saw a nurse do that, and I said, why are you drawing that back? And she said, and she was the one, and it made sense. If they have this little concentration and they mix the two, and the rate's different, they're getting for the first hour or whatever, the hospital, because it doesn't go very fast. Anyway, so you get the extensions, you have them put it in the pack, you have them load up the pump, you watch them do it, you try to prompt them as much as they're needed to be prompt. You have them wash their hands, put the gloves on, flush it. Initially, that's the only time they flush it, and the reason they don't flush it after that is because if you flush in between bag changes every 3 days, what you said, you're going to give them a bolus. Having said that, if they have a double lumen line, you still have to teach them how to flush.
Flush the one that's unused.
That's not being used.
That's not being used. So you still go through, I do a teach on how to flush the line.
Okay.
Even though I have a single lumen, it's kind of crazy. Okay, now you have two, but you only can have, or if they have something in their chest. The idea really is for them to get used to this end cap and what that feels like, and getting the air out of the tube, out of the syringe.
So do you have the nurse go ahead and prime the extensions?
They prime the extensions and put them on in the hospital. They do all that because I don't have a license.
Yeah, that's why I had you do it at St. Paul.
Yeah, they do it all. I ask them to come
because we have different stuff, to make sure she put it on.
Yeah. So I bring in our own stuff.
They use different.
I bring in our own stuff, and
yeah, I think I had some stuff.
Oh, you mean to hook them up because you can't do that in the hospital because you're not.
Well, she just put the extension on it, and he hooked himself up.
Right, that's what you do. You watch them hook them. That's why I said you watch them hook themselves up. You watch them turn the machine on. You are there at initially you give them that book the first time.
But you can't touch the patient while they're in the hospital. Okay.
So if you want to teach somebody and you don't have one of these handy-dandy lines.
And she's the only one that has one right now. I would love that.
I'm the only one that has one because they were laying around here and everybody went, I don't want that. It's probably pretty prohibitive. I don't know how it was laying around and it was dirty, and I said, can I have that?
Do y'all have a chest over here?
No.
Cody told me there was a chest somewhere.
Well, if there is.
Well, we used to have one down there.
Chester chest with a
So it had ports and everything on it. We used to have one. Robin brought it to do some teaching.
No, CarePoint has one. That we can ask to use.
Is that the one that Robin brought with her?
Yes. But Cody told me a couple of months ago we have a chest. So
well,
if you don't know there's a chest, then he may not know.
What do they know?
But if he does, I'm going to go.
It's like laying around.
I'm going to go ask him if we really have a chest, because if we do, we're going to mention.
I have a quick question to ask you about the Primacor.
Okay.
If we're changing it every 3 days, how often do we want the patient to weigh themselves? Because if
you
the
want
doctor...
the patient to weigh themselves daily. Because if they have a 3-pound weight gain overnight, then they've eaten too much salt, and the chances are with that 3-pound weight gain, that's the magic number. They have 1 or 2 fluctuation, no, 3. it's 3 pounds at night, that's what we teach them, 3 pounds at night, overnight, or 5 in a week. You have to, we want you to call your physician or call your home health nurse
That's
so
what
they
we've
can
always,
notify the doctor.
always.
And then, if you notify the doctor with that, weight change, they may say, why don't you give them a little bit more Lasix and do some labs and we'll check the potassium, you know. But, I mean, they'll adjust.
So if let's say everything is working the way we want it to work, they lose maybe a lot of weight, Primacor, let's say 3 mics per kilo per minute. So we're going to change the rate.
Yeah, they do change the rate if they lose a lot of weight. But it's very, what we found was like 10 pounds. You think 10 pounds? It turned into point 0.3 or 0.1. I mean, it was
Mics. Yeah.
Mics. It wasn't that significant. And so the physician, and the other thing, if they're doing okay and they've lost a lot of weight,
They probably needed to.
they don't want to fix something that's not broken,
Just want to leave it alone.
even though it makes sense, because that was our thing. Well, how come they've lost weight? Don't they need to change it? No, we don't want to change it. It works. Even though they've lost weight, it's working. We're not going to fool with what works. So that's out of Medical City. That's both of them, Medical City and Baylor. We're not, you know, they're tolerating it. We're not changing it.
But there's usually orders on there to call the physician if there's like a large range. If patient loses this much weight, call.
No,
It's the pharmacist that, the pharmacist is the one that gets that order from the physician. And she can't take an order from us necessarily, a verbal order. She has to get it from the physician. She can take a written order if you happen to be. But so if you have some concerns, you can talk to the pharmacist here who mixes it up and say, you know, we've been waiting and he's lost 20 pounds. Again, if he's tolerating that 20 or 30 pounds, they call, and 9 times out of 10, they do. I mean, it's a good thing. If you want to ask, go ahead. But 9 times out of 10, it's been, now they're tolerating it. We're not going to do it. We're not going to do anything different.
Yeah, and for the ones your stands on you, call me, and then either you or I will call the pharmacist, and the pharmacist is usually the one that has the contact with the doctor, just because they can take orders from
Verbal order.
without it being necessarily signed before it can be implemented. The nurses can't do that.
Well, that's strange because we can with PD Home Health
You can what?
write verbal orders.
You can write verbal orders, but then they have to be signed by the physician.
We email it back to the company and then they'll fax it to the doctor.
Right, but pharmacists don't have to do that. Pharmacists can literally write the orders from talking to the physician without having to fax it over. And I did print a physician's, I got really concerned about some of the things that you and I were talking about and that I had talked to Cheryl and Lilia about, because we're going to have to tactfully stop some people from sending emails as orders. But once, because we can't, nobody, even the pharmacist, can take an order from an email from a case manager at some hospital. I mean, you can't do that. That's not a doctor's order. But when the pharmacist actually speaks with the physician and puts it in the computer, the Texas State Board of Pharmacy and the Texas State Board of Nursing have issued a joint position statement. And for purposes of specialty infusion pharmacies, and when it's just strictly home drug management for the patient, RNs can accept orders from the pharmacist. Okay? And so I'm going to print that out. I'll let you know. I'll fax it over to you now.
But we can't take a verbal order from a doctor and then give it to a pharmacist.
No, we can't.
Okay.
No, we can't. Because the pharmacist can't take an order from a nurse, because we're not a designated agent of that physician.
Unless we're...
Now, if we worked in the doctor's office...
Right. Yeah, because that's what happened to me. I was like, when I came here, and I was like, but I used to...
I know.
But I worked for my doctor.
And it was very confusing for me, Susan, and I got really, the other day, it was, all these things were going through my head. It's like,